Relatively explicitly, I've listed off the primary questions that I think should be asked. Certainly, again, there's going to be nuances of how we navigate a conversation with somebody, right? But it's usually more in this kind of dialogue, open-ended question type of format. Yet the terminology is called paralleling, where in the back of your mind, I know all the elements I need to be getting, and I'm just going to have a conversation with you, and I'm going to try and tease out those things as we go, versus I think the more linear approach that is taken early on in careers is that, here are all my questions. I'm just going to run you through these questions and get my answers, right? But you can, statistically, 87% of the time, the diagnosis comes out within the first 3 to 5 minutes, right? And that's not like my own statistics, right? They've done these statistics where they actually film sessions within the physical therapy and the orthopedic realm, where that's as quickly as the diagnosis can otherwise be determined based off what the person says. And the more that they say, the better off, and the quicker you can start to make these determining factors. The ones that I do want to kind of focus on here, because I think that they are relevant, and I'll zoom in on it, is because this was a relatively new paper. If I highlight over it, you can see that it was published in 2020. And I think it's also important just to acknowledge that all the references, not only the end notes, but also the references themselves, I've tried to hyperlink. So if you're going through this and you're like, I have no idea where that comes from, and you double click on it, it should take you immediately to your references at the bottom to the hyperlink. Because the annotated bibliography makes up 50 pages, which is over half of the manual that you have in front of you. And then, again, I tried to make it streamlined, yet also simultaneously extensive. So the red flag screening, so you have level of concern. It's on a sliding scale. Again, it's not a dichotomy, right? So do you have no concern? Rarely. At other times, right, you have some concerning features, and whether you need to have an emergency referral or otherwise, does this person belong in your clinic? And so in that determination of red flag screening, again, we won't go thoroughly into this, but enough that the ones that you don't want to miss, right? Fracture, infection, cancer, massive acute rotator cuff tear, avascular necrosis. The other one that I'm going to highlight is, I thought this was really cool and something that has been helpful for me, because I think that there's 5 implicit questions that every patient comes in with, whether they know it or not, right? The first is, what's going on? Why am I hurting? The second is, what are you going to do for me as a physical therapist? What am I going to do for myself? How long is it going to take? And what is it going to cost me? People say cost and people immediately think finances. No. The most precious commodity that people have is their time and their energy. And so I'm going to tell you that, I don't know your insurance policy. I can't tell you, unless it's a cash-based clinic or model, I can't tell you exactly how much it's going to cost. You have to work that up with your third-party payers. I certainly can be helpful in disclosing what our billing looks like. That being said, more importantly, I'm going to ask for your time. I'm going to ask for your energy. This amount of time per day would be my recommendation. However, we make this individualized and customizable to you. But to answer that fourth one of how long is it going to take is prognosis stratification. This is something that we've really emphasized within our residency, within our clinic, because it's hard. If you are a young clinician, you haven't really had exposure, if you're not really familiar on the data analytics or informatics of what is the typical rate of people that have rehabilitation and for their rotator cuff tendinopathy, how long is that going to take? Right? It's somewhat hard. This scoring system allows you to help to stratify that a little bit more effectively. So the duration of their symptoms upon initial eval, was it a gradual onset? They have concomitant psychological complaints, which if you don't know what questions to ask for that, you can use a functional outcome measure, right? Kinesiophobia and otherwise. Repetitive movements are painful. Shoulder pain and stratification, again, if you're not, the neck pain in the shoulder, 0 to 10 and 0 to 18, usually require a little bit of further breakdown. But again, if you just click on the little 25, it will give you what that looks like and how to actually properly stratify it. And the risk of having pain over 6 or 12 weeks beyond how they actually present. Again, we could really talk at length about the subjective examination and what questions to ask, but I just don't think that that's where we want to spend the majority of our time because we are somewhat limited. So I put some helpful reminders. So on average, it takes 92 seconds for patients to explain the problem if not interrupted. Providers are 7 times more likely than patients to interrupt. I agree with that. I definitely am more likely to interrupt at times. Yep. Accurate history taking will provide 80% of the information required to develop the terminal diagnosis. And then to help you with further stratification as to what they may be coming in with. So we've used what is known as the STAR framework, which is currently taught on the OCS as far as shoulder stratification and diagnosis and classification. I know Lori Mishner, a huge shoulder giant out of USC, was behind that. I forget the other authors, but she was definitely a name that rung out to me. And they talk about rotator cuff syndrome when they lump that in with subacromial pain, instability and or labral pathology, mobility deficits and or adhesive capsulitis, and other. Again, it may seem like an oversimplistic model, but oftentimes taking the complex, making it somewhat simple, allows for better stratification and less paralysis by analysis. And so taking that framework and then breaking out what is our questioning and then what is our physical exam will be the steps in which we go through that. So your step 2 is really physical exam decision-making in those moments between your subjective and your objective. And then your physical examination is where we'll start with our demonstration and our breakout. Any thoughts or questions at the moment? I said more of a monologue rather than, or more of a dialogue than a monologue, but maybe we'll warm up as we go. All right, so postural assessment. So I think for this, we will take a volunteer. If anyone wants to stand up. Great. Come on up. All right. Are you okay taking your shirt off?
Yeah.
All right, great. Why don't you take off your hat and we'll go from there. All right. Any shoulder pain or history that we need to know of?
Labral rotator cuff repair 20 years ago, and acute shoulder pain. Do some gardening yesterday.
Got it.
Busy weekend. Yeah.
Fair enough. Okay. Perfect subject. Thanks for volunteering. All right. Why don't you put your stuff down and then we'll have, I think maybe the better way to play this is just in the open space on the outside here. And I'll just flip this around so we can see. So the first thing that we see within the postural assessment, and for clarity, I do preface that there's a full postural chart and checklist that you can do from multiple different angles and planes of motion. For our intents and purposes today, we're going to focus on hands on hips. And then there's also a wall press test. So I'm going to, and I'm sorry, I forget your name. Tree. All right, Tree. So I'm going to have you go hands on hips. So when we're first observing, right, we can look at posture and kyphosis of the spine and things of that nature. Is it okay if I put my hands on you? Yeah. Right. So one of the most effective ways to determine scapular winging and or any atrophy and muscle bulk alterations would be in this position. And then you can have them exaggerate it by doing a couple of strategies. One, Tree, if you actively push into so when he pushes in, things become a little bit more apparent, a little bit more medial border winging on the left versus the right. When we look at the overall gross muscle bulk, which side, if any, seems to be more developed?
When he's pushing into his hip.
He's going like this, yes. Yeah. Or at least I hope that was the intent of the cue.
What was your cue on that?
Yeah, it was like this. Yeah. And then if you bring your shoulders back, your elbows back just a little bit. Yep, that can also. Right. So what I see is a little bit more upper trap development here. I would say that there's a little, again, it's a little bit subjective. We don't have good objective means by this. All you're trying to do is determine, like, what is my next step? What are other things I may want to look at? The other one would be doing a wall press. So we're going to have you, I think the closest wall that would be available would be just over here. So we're going to have you go over there and face the windows tree. And then JC, feel free to, you want to run this one?
Yeah. So for this one, you're going to put your hands at palms on the wall. Sorry, Graham. And then you're going to just kind of stay upright and you're going to push against the wall. And so for this one, what we're looking for is the same kind of similar things, like looking at medial border prominence, inferior angle, like protruding. It's kind of hard, like with the lighting kind of obviously matters. So like coming from the side too, if like you do come from the side here, you can see a little bit of inferior border, like winging, but I wouldn't call it wing because I want to try to be light with that term with long thoracic nerve injuries. Go ahead, you can relax for a second. And so if some of you guys want to come over here and see this on the side, it's more so the reason why you're doing this is because you can see whether it activates more of the serratus. And so go ahead and push into the wall and you see how it pops up just a little bit more. And so this is something where in terms of when we go into our intervention later, this is like, we'll take this under consideration. And so the other things you can look at is, does he use upper trap more for this? So it's more going into that movement kind of analysis as well. All right, relax. So the other thing to mention is based off of that hands-on hips posturing, that's our atrophy sign. So if someone does have like divoting in their like infraspinatus area, you're obviously worried about the suprascapular nerve palsy. And then same with like for this one here, if you're seeing like inferior border prominence, like significant border prominence, you're thinking about the long thoracic nerve. And again, those are zebras, but definitely like can occur.
Yeah, so examples in your manual within the annotated bibliography would be shown like this, where there's just a little bit more to look at. That's good. A little bit more to look at on these examples rather than on tree.
Yeah. Thanks, Tree. And then we still have your, we're going to go through more.
Yeah.
Yeah.
All right, and then, so publication as of this year in the physical, in PTJ, 2025, ruling out cervical spine contributions and shoulder pain, right? And the consensus of the experts that wrote the paper, your cervical spine should not be a component of every shoulder that you see, right? It should be determined by a couple of things. One, your subjective screening questions, which I've listed the criteria here that would be required for further assessment of the cervical spine. And then Rob Weiner out of Texas gave us a classic predicting elements of what would be cervical radiculopathy. And even if it's not a true radiculopathy where you're having hard neurological symptoms, this cluster can still be a determining factor as to what the contribution is of the cervical spine in referring pain to the shoulder complex. And you're looking for what Maitland would call your concordant symptom. Is it the pain and the primary complaint that they're coming in with? I would love the opportunity to go through cervical spine, but we're gonna focus solely our efforts on the shoulder complex for the moment and for the remainder of the course. So the way that we've broken it out is that you have step 3C, and then you have more pathoanatomical diagnosis workflows in 3D. Universal shoulder assessment. Everybody gets these assessments that you see here. And then you break it out into what is your primary leading differential diagnosis based off the subjective and the medical history that you've otherwise reviewed. And then we'll run through what would be a column. So this is, if we're thinking algorithmically, it's like, which column do I want to run? If you pick the wrong column, it's okay. You're just making sure and giving reassurance that these structures are not a contributing factor. And but the better that the more often that you think this way, the less you'll take a wrong turn in your assessment, I assure you. Okay, universal shoulder assessment, standing flexion, unilateral and bilateral, and then shoulder abduction. Okay, if painful arc or altered scapular kinematics are identified, approximately in a third of cases, then you would go into a scapular thoracic differential. Tree? So this is so I'm big on numbers. It helps me. I have this underlying bias that my own human biology is inadequate and is subject to error. So I'm going to just have you face the screen, and I hope that's okay. Maybe if you move up just a little bit, maybe 2 feet, and now I'm going to just kneel down and get out of the way here. So we'll call the acute shoulder your affected shoulder, right? So that is your right. So we're going to ask for you to go into unilateral, that is left shoulder flexion. And usually when I'm in clinic, I'm not using these terms. I'm saying, okay, I need you to, monkey see, monkey do. I'm going to have you go feet together, stand up in your best possible posture. And then I'm going to have you bring your arm up overhead. There's definitely the counter argument where people would say, well, you're putting constraints on the system that he's not actually moving like he otherwise may if you give him these instructions. I want to make sure that I'm consistent such that any deviations that I see from person to person is the nuance of those persons. So you're correct. I am putting on some constraints, but it allows me to have objectivity and consistency across not only this patient, but every other patient that I see. So I become more and more nuanced in picking up these subtle deviations. That is, again, a principle of Shirley Sarman as well, in pattern recognition. Okay, all right, so Tree, as you were. I go unaffected arm first, and while he's coming up, even though I'm somewhat blind to it at the moment, feel free to shout out, we're looking for any altered movements within the glenohumeral as well as the scapulothoracic joint. So we'll have you bring it back down. Typically in clinic, I'm either going to use a wearable device or I'm going to actually use a goniometer to capture that flexion as he goes overhead. Once more, Tree. Okay. You get some nods. People like it. Yeah. Mm-hmm. Yeah. Okay. All right. I would say there's a little bit of elbow flexion, right? But he also dissociates his shoulder complex pretty well from his cervical spine. Great. Yep. And then again, you would do that same thing other side. For time, we won't. And then you go right into bilateral elevation, and then I go into abduction. So we'll go unilateral abduction with the left. Again, I go monkey see, monkey do. Once again, elbow straight, boom, and as high as you can. Right. A little bit more of a cervical tilt, slightly at the end, and then back down. And you're looking at both concentrically and eccentrically how well they control the arm. The other thing that I typically see is that people are missing this cone of space up here, and they'll go into shoulder drift, as I call it, or flexion drift, where they go whoop, right, and they can't access this. And for my postoperative shoulders, I describe it as this is good rehab, this is great rehab. Of like, how can you get into that upper echelon of cone of space? You're nodding your head.
I have a couple of patients right now where we're trying to get that.
Yeah. It's hard without getting like abutment or additional symptoms at that end range at times. Yeah, we'll talk about that with our range of motion assessment. Okay, and hypothetically, maybe someone else knows it on themselves. Do we have altered scapular kinematics? I don't know if Tree's our best example, but we'll run with it. All right. And then JC, why don't you use a scapular assist and go from there? Yeah. So hypothetically, he either has a painful arc and or, do you have a painful arc on the right side? All right, we'll run with that.
Yeah.
Yep.
Cool. All right. So we'll do the first one, the scapular assist, and then we'll do scapular reposition after that. So scapular assist, like I would have him run through that single arm elevation. So go ahead and do that. Go on up and then come on down. I would ask him like when he feels the symptoms. So it's more of looking for that painful arc. From there, I will hold the inferior border, and the medial border is on like where my thumb is. My left hand will be on top of the spine of the scapula, and then as he raises on up, I'm using my thumb on the medial border to help with that upward rotation of the scapula. Then go ahead and come back down. I'd have him do that a couple times. Go ahead. And then I would ask him, like, do you feel any improvement here? Any improvement in that painful arc?
Yes.
Okay. So if from there, then I'm like, okay, well, check the box for upward rotation. So therefore, when I look into my intervention standpoint, I need to make sure I work on upward rotation. From there, I'd also do posterior tipping or scapular reposition. So I would, rather than like kind of similar with like my hand position here, for upward rotation, I'm using more of like my right hand and assisting with upward rotation. For this one, I'm using more of my top hand and working on posterior tipping. And then I'll have him go ahead and raise his arm up. And I would follow along with this one and then go ahead and come back down. Try to stay a little bit, rather than getting your shoulder range from like TL junction, let's try to keep that a little more stiff. So I usually just say, all right, brace the core. Now go ahead and go on up. Good. And then come on back down. How was that one?
Easier.
Easier? Which one was which one was a little better? The first one or the second one?
The first one.
The first one? Okay. So from there, then I can prioritize whether I would look more for upward rotation, but still, like, because that did improve his arm elevation, I would also work on posterior tipping. And so we'll go on through that. Now, something to mention here is that just to go into like more of why this like painful arc occurs, is that what the abutment of tissue underneath the humerus and the acromion, there's typically on normal, in normal posture, in anatomic posture, typically it's around 12 millimeters of space between the acromion and the top of the humerus. And then there's obviously tissue between the two. Regardless of you raising your arm up, you're gonna have tissue abutment at the end. Now the question is like, when does that tissue abutment come on? So you have, if you are anteriorly tipped forward, then obviously that space decreases to, let's say, 9 millimeters or so. So therefore that tissue abutment becomes much earlier in that range of motion, which is like what kind of why that you feel that painful arc in a way. And obviously there's, humeral elevation that comes from maybe being deltoid dominant and so on. We'll go over that later. But that's really what your hands are doing, is creating more space underneath the acromion. Cool.
Great. And again, feel free to holler. Tria, are you still okay to be our model? Sorry. And if you can say no, that's okay too. Okay. Any comments? Again, feel free to shout them out, raise of hands as we go. So I kind of listed it off of there in the manual. If 2 or more of these are positive, proceed with scapular evaluation algorithm. Otherwise, proceed with diagnostic workflow. So for the moment, we're going to proceed with diagnostic workflow, and we're going to kind of hone in on each one of these columns. So, right, there's over 170 different tests that have been described as far as being quote unquote special within the shoulder. We've all heard like the limitations there within. If any of them were really good, there probably wouldn't be 170 of them. And so when we went around the room, no one was like, oh yeah, I want to know about the psychometric properties of the special test of the shoulder. And I hear you, because it is a little bit dry. What I have done, as I alluded to, is like if you click on this, I've tried to put them all into a chart as far as the psychometric properties.